my general purpose really is because I was sort of born and brought up with the National Health Service, and I've lived with it, and I've struggled with it, and for the last nearly 30 years now, I've grappled with the problems that it presents, which are many at different levels. So I thought the best thing I could do would be to talk you through the problems that we have faced at different stages in the development of the National Health Service, and which we still face, quite serious fundamental problems with it, leaving you to make whatever analogies you choose to make with your own system. I'm not an expert in the American system. I observe it with a sort of fatal fascination that that people face. You know, it's sort of, sometimes I can hardly believe it, what I see. But mine not the reason why. And I'm not going to draw explicit parallels between the UK and the USA. I don't feel competent to do it, but it might nevertheless be an interesting area to discuss. I mean, I talk about how problems present themselves for us, and you say, well, we don't have that problem. And I say, don't you? Or maybe it just crops up in a different institutional guise, because I think the problems we face are faced by everybody, but they're faced in a different way by different people. And for example, we don't have a problem with cost control. You mentioned cost control being a dominant. We don't have a problem with cost control because we have a single payer, and the single payer decides how much we're going to spend, and that's it. So instead of having a problem with cost control, we have a problem of what the hell to do with the small amount of money we have. Okay? But cost control isn't the problem. Priority setting is the problem, which is why the whole issue of priority setting and rationing dominates our discussion. And cost control, you won't hear anything about it. People always complain the budget's too small, the health service is underfunded, etc., etc., etc. But we don't talk about cost control, ever. But we talk a hell of a lot about efficiency and cost effectiveness and so on. So I think some of the problems just don't appear for other reasons, but it's like balls in a bowl, you know. You take one out and all the others adjust. Push one down, all the others move slightly. And I think that's what happens in this system. They're very tightly related, all these different issues. My plan in this first session was to talk about a need-driven system, which is what the NHS claims to be. It claims to be motivated by the objective of meeting needs. And I want to talk a little bit about why we think we have a need-driven system rather than a demand-led system, for example. There's a big difference between the two. I want to say what I think rationing, the word rationing means, which is quite important because, as Dave said, the word rationing is invested with a great deal of emotion. And so I think it's very important for people to say precisely what they mean by it, so that we know whether this emotion is justifiable or not. I want to talk about the role of ideology, because I think unless we go fairly deep into people's ideological beliefs, we can spend an awful lot of time discussing things that come to the surface as if they're matters of fact, but actually are matters of value system. And it also means that the way you appraise a system for its effectiveness or its efficiency will depend upon what you expect the system to deliver, and that depends upon the ideology underlying the system itself. So I want to talk a little bit about ideology, and then I'll come back to the rationing. What kind of priority setting is rationing supposed to be serving in a system that purports to be driven by need rather than anything else? And need is a very slippery concept, which I'll have to go into a little bit more deeply as we go along. So that's what I plan to do in this session. Right. So, first of all, let me start off with this rationing business. As far as I'm concerned, rationing is simply priority setting subject to resource constraints. Okay, there's nothing else to it. That's all it is. And since priority setting subject to resource constraints is something we all do all the time in all aspects of our lives, there's nothing peculiar about it. And there's nothing peculiar about it in the healthcare system either. It has always happened. It's happening right now. It always will happen. It has to happen. So I think the only thing that's different is that it's happening now in a rather more public forum than it ever used to happen. It used to be settled quietly by consenting adults in private. And so long as we accepted the notion that doctors know best what's good for us, it's fine. But once you start adopting a consumerist perspective and you start challenging the rights of experts to make decisions that really require them to know a lot about the values of the people that they're treating, then it gets rather more difficult to pursue priority setting in an intraprofessional, discrete way. It shoots out into the open and it raises some rather nasty issues. And the reason why it's particularly nasty is that rationing involves saying that some beneficial things are not affordable. Okay, it's all very well to say this is a waste of money, it doesn't do any good. But what about if you say, well, it does do some good, but it's not worth it? Okay, and you're saying that about an individual. Okay, that we're really saying in this debate that our priorities are such that these people can go on suffering in order that these people can be healed. Okay, now that's very nasty. Okay, and yet it's absolutely inescapable within the system. It absolutely has to happen, unpleasant though it might be. And I think this business about potentially beneficial healthcare activities having to be withheld is the thing that sticks in people's throats, really. And there's a great tendency to say, well, we should spend more money on healthcare. Okay, so I'll come back to that as a possible solution later. That's a very common thing to say in the UK because we don't spend all that much on healthcare. So we've got plenty of room. We've got plenty of room for expansion. It's a bit more difficult, I guess, to say that in the United States. You spend 2.5 times as much per head on healthcare as we do. 2.5 times as much per head. Okay? And you have rationing problems. Well, just think about our rationing problems. Okay? And when actually they're not so different, which is the amazing thing. And of course, because the thing is out in the open, we can't really go on doing priority setting without it being principled. I mean, in a democratic system where large parts of healthcare are financed from the public purse, as it were, people want to know what the principles are. Otherwise, you just get into a situation, it's all sort of political favoritism. And political favoritism is not unknown in democratic societies, but it's hard to defend. So if we're going to finish up in a defensible position, we've got to be able to appeal to some principle or other which we think should command general support. So one of my abiding pursuits is to try and find out what are the principles that make sense of the kind of decisions that people make, because often they make the decisions without thinking about the principles very explicitly, but then you think afterwards, well, what could the principle have been? And that's one of my interests, is teasing out the principles and then asking people whether this is what they had in mind. And then if they said, well, yes, it is, and I say, well, do you realise that if you actually apply that principle over here, you would have come to a different decision from the one you came to. That is, the principles you purport to espouse, you don't apply consistently. And then they say, but that was a different situation. And I say, okay, how is it different? Okay, why does this principle, which works here, not work there, and so on? So one's doing a kind of what you might call ethical psychoanalysis of people. And I think a lot of what's going on in this field is about that. It's trying to find out what people's notions of a good society are at that very deep level. What is your notion of a good society? What should a good society be doing for sick people? This is why I think we have to get down at some point to ideology, which I'll come to in a moment. But in the meantime, the whole thing is very nasty. And it's nasty in a variety of different ways. It's got all sorts of different bits of nastiness in all this. For one thing, intellectually, which is the bit that interests me most, intellectually, it's very difficult to fit all these pieces together into any sort of coherent framework that you can use to analyse things. So it's very demanding. Of course, the politicians hate it all, and the British politicians pretend it isn't happening. I mean, as far as they're concerned, they say, we provide enough resources to meet all reasonable clinical needs. Okay, reasonable, all reasonable clinical needs. Okay, and so they pass the buck to the doctors, and they say, well, the rationing, I mean, this is done by doctors, not done by us, and we all know doctors are very honest, public-spirited people who never pursue their own interests if ever they conflict with those of their patients, and the patients trust them, and so the buck is passed by the politicians to avoid the embarrassment of having to stand up and be counted when some nasty decision is made, like denying treatment to some class of people. Psychologically, of course, if you're the person at the point of contact with the person who is being denied treatment, you carry a big psychological burden. I mean, that's a very difficult thing to do. So at the psychological level, it's also very demanding. And when it comes to the ethics of what's going on, there isn't one clear ethical principle that you can hang on to and say, well, I now my flag to this mast and that solves all the ethical problems for me. It isn't like that. Nearly all ethical positions are, as they say, contestable. That is to say, there's some other ethical position which is equally defensible, and so there's a continual clash of ethical principles which the philosophers usually then chicken out on and say, well, this is no principle, they say, no principle trumps any other principle, and so a compromise has to be struck, and then they just leave you to sort it out. Okay, I've always found that very unsatisfying myself. I think, okay, so how do we do that exactly? And I'll come back to that, because I think economists in principle have a better approach to that, though in practice they don't carry it through. Now, can rationing be avoided? People say, well, we could avoid it by spending more money on healthcare. Well, I don't think Americans are any longer under any illusion that by spending more money you solve any of these problems. Maybe we don't need to think about that too much more, but in the British context that is often said. And then they say, we'll take the money away from defence, and it only needs, another month of NATO airstrikes, and that argument will be extremely strong when people start asking, where's this money coming from exactly? Okay, well, it's got to come from somewhere. Eliminating waste within the system is another popular thing to avoid. They say to avoid having to think about rationing, we shouldn't start thinking about rationing till we've squeezed the pips until they start squeaking, But and that might take quite a long time. Well, I think there's no doubt that the healthcare systems on the whole run quite inefficiently, and so there is plenty of scope for doing that, and I suspect a lot more scope in your system than in ours. But even though there's plenty of scope in ours, and then also stop doing totally ineffective things. I mean, it's amazing when really good clinical trials are done of practices that have been going on in healthcare for a long time. It's often discovered that they don't actually do any good. And it's amazing how much goes on that's never been properly evaluated from a scientific point of view. But you see, the point is, each one of those, no matter which you had a go at, each one of them offers you more resources to use. Okay, there are different ways of getting more resources to use, but then you face an issue. So what are your priorities with these extra resources? So you then got to face up to the rationing issue again. You know, what are your priorities? Should we be putting this money to improve the health of poor children, or should it go into Medicare? Or, I mean, where should it go? Should it go into heart disease? Should it go into prevention? Should it go into rehabilitation? You've got to have some sense of priorities about what's the most important thing to do. So I think with each of those three, you still have to think about priorities. And the last one, stop doing relatively ineffective things. That is precisely what the priority setting game is all about. It's trying to judge which are the more and which are the less cost-effective things. So the last one isn't a way of avoiding rationing. It is what rationing is all about. So I don't think it's worth giving a lot of thought to ways in which rationing could be avoided, because I think they just don't exist. There aren't any. So that's the bit I'm going to skip over, and I'm going to jump to about 2 or 3 pages on. Rationing is inevitable. Even while waste is being eliminated, ineffective things stopped, and the key issue is how best to do it. Now, let me just pause there, because I've run through a lot of ground clearing activity, and you've all sat there very passively, sometimes nodding your head. I haven't seen anybody shaking their heads yet, but is everybody still happy? Because I'll press on. Okay, I'm pressing on. Okay, I'll press on. Okay, well, now I turn to ideology. And in what I'm going to say now, I've been heavily influenced by Donabedian. I don't know whether any of you have read the works of Donabedian, but I think he was an extremely shrewd observer of the healthcare scene. And his great strength was sort of categorizing positions, and which is what I like doing. And so what I'm now going to say has been heavily influenced by him. And to polarize ideological positions, I think it is a good intellectual analytical technique, because it helps you to draw distinctions rather closely. And I think in reality, people are in most people are in a muddle in the middle somewhere, okay? But the middle is a muddle, okay? And so I think in order to avoid jumping into the muddle, I think it's best to keep out of the middle, if you don't see what I mean. So I'm going to keep out of the middle for a while, and in fact I would be quite prepared to enter an argument that I think the middle is actually untenable. But that is to say, it's not sustainable. But we'll see, that's another bit. The two polar opposites are the libertarian position, which I guess is epitomized in the extreme by philosophers like Nozick and political philosophers and economists like Buchanan, and egalitarian positions, for which my personal hero is Amartya Sen, a recent winner of the Nobel Prize in Economics, much I understand to the chagrin of the Wall Street Journal, who thought this was terrible. But never mind, not in the business to please the Wall Street Journal, are we? And the problem arises right here in this very first general position, because the libertarian position is achievement must be rewarded. Okay, personal achievement must be rewarded. But the egalitarian is saying, yeah, that's fine, but lack of achievement mustn't be punished. Okay, right. Now that's a difficult thing, a little bit of balance striking to begin with. And how can you reward achievement and not punish lack of achievement? Yeah, I think that's a big issue there. And if you want to help the people who are not good achievers, for a libertarian, the solution is private charity. Okay, the people who are doing well should, as a matter of private charity, help those who have not done so well. But for an egalitarian, that isn't good enough, because that's quite capricious. It depends upon, there's no guarantee that all the people who are in a bad way will necessarily get help. It'll depend upon the wishes of individual donors. You may get a tremendous amount of help towards people in one area or in one situation, but not in another. So collective mechanisms are needed if people are to be dealt with equitably. That is, if people in similar circumstances get similar help, okay, which private charity is not good at doing. You'll gather from all this that I'm heavily biased in the egalitarian direction, but perhaps I should say that clearly at the beginning, because my comments are influenced by that. To a libertarian, freedom is the supreme good, and it shouldn't be sacrificed lightly. To an egalitarian, freedom is about real opportunities of choice, and other people's realm of choice may need to be curtailed in order that the others can have wider choice. So this isn't about freedom, it's about equal amount of freedom for everybody. So it's very much more about people having as much freedom as is compatible with everybody else having the same amount of freedom, okay, which is an important twist in the argument. And equality before the law is the key concept for a libertarian, and freedom dominates equality if ever they conflict. For an egalitarian, equality of opportunity is the key concept. And if we don't have equality of opportunity, then all the good things, moral things associated with achievement tend to be undermined somewhat, okay? Because if you never had a chance, you can't really be blamed for not achieving very much, whereas if everything was handed to you on a plate, what moral claim can you make simply because you achieved a lot and the other guys achieved nothing? Okay, so from that point of view, the equality of opportunity becomes a key concept. Yeah, oh good, I've got someone to stop me talking for a while.
Well, I'm going to put you in the middle. I'm not let you stay on the ends quite as much as you want to. One philosopher who takes a position somewhat in the same direction as the egalitarian position is John Rawls.
Yeah.
Two principles come out from that side, and maybe you can address both of them. One is equality of opportunity, which is everybody has a similar starting place.
Yeah.
And the second says something about, and it can be interpreted differently, the equality of outcomes.
Yeah.
And in that regard, are you making a distinction between those two? Are you concerned about outcomes? What do you mean by opportunity?
Yeah, I'm more concerned with outcomes than I am with process, but sometimes if you want to achieve equality of outcomes, you have to think about process. That is to say, the fundamental objective must be about outcomes, and the other points are instrumental. Now, I know some philosophers think that process is an objective, a whole set of objectives in their own right that are associated with process, to do with participation and so on. I personally, if you ask me personally, I'm a sort of rule utilitarian in this game. Okay, I think consequences are very important, but the consequences are not going to be always judgeable at the level of individual actions, but at levels of social rules. And I would choose the social rules that are likely to generate the best outcomes. And I think that's what Rawls was on about when he was talking about giving the worst off people a right of veto over changes that in the society, so that we only did things that increased inequalities if they were approved by the worst off group of people. That's a process rule, as far as I'm concerned. Might be a good rule, might be a bad rule. Is that okay? No.
Yes. Can I follow up by asking about a position in the middle, which might be called a safety net rule?
The which rule?
You might call it a safety net rule, that's distinct from an egalitarian rule.
Yeah.
Namely, that society, however it reaches the decision, defines a minimum decent level of this or that it's trying to achieve, and devote the resources to achieve that.
Yeah. I think you have. Yeah. I think the safety net rule may not at all be anything to do with ethics or morals. It may simply be an insurance policy which has no moral content whatever. May well be that since we don't know what sort of situation we're going to be in during our lives, we prefer to have society structured so that if we turn out to be one of the casualties, we'll be caught up somewhere. So this is actually our informed self-interest. So one justification for safety nets, which has absolutely nothing to do with morality, is the social insurance principle. And I think that a lot of people advocating the safety net rule, particularly from behind the veil of ignorance, are actually thinking in insurance terms, not in morality terms or ethical terms, I would say. Now, of course, that doesn't mean that you're necessarily thinking about it in those terms. You could also be thinking that you don't want to live in a society where people starve, whoever they may be, even though you know damn well it'll never be you. You don't want to live in a society like that. So there can also be an ethical element in it. And then the issue arises, is this a general position about reducing inequalities, or is it about avoiding stark deprivation? Okay, because those are not the same issues. Okay.
That's why I'm suggesting that's another position between the two. It's tenable.
Yes.
Reducing inequality, not eliminating the equality of opportunity is impossible, so you cannot be.
Yeah. Oh, well, I think a lot of these aspirations are impossible. That doesn't make them not valid as aspirations if they are the rule that guides you. Incrementally, you want to move in one direction or another. I think the reason for the maintaining clearly the distinction between helping the people at the bottom and reducing inequalities. Reducing inequalities, you may be able to do most efficiently by screwing down the people at the top. Okay, whereas if your object is to help the people at the bottom, you don't worry about the people at the top. Okay, so it does lead you into quite a different policy appraisal framework. Which of these two you're pursuing? My own personal position is that I am an inequality reducer rather than help the people at the bottom person. But I mean, that's just me. You don't have to be like that. Anything else on this broad ideological issue? As I said, there is middle ground, but I think it's difficult, and I'm not going to pursue it in great detail.
Return to equality of outcome as
Yeah, equality of outcomes is my main theme tomorrow morning, first session. Okay? If you can wait that long. Now, all those positions that I just mentioned are general ideological positions, not necessarily to do with health. It could be to do with income or education or wealth or anything. I mean, but I now want to talk a little bit more about their implications for health, specifically, or I should say, for health care specifically, which is an important distinction between health and healthcare. And healthcare systems, whether they're ostensibly market orientated or not, have to deal with a set of problems. They have to say, where does the demand for healthcare come from and how is it mediated? What happens on the supply side? How is that mediated in a different system? How are the two brought into some kind of balance? And some sort of balance has to be brought about. So there's a question of adjustment mechanisms. And then the fourth element is, how do you evaluate alternative situations? So we've got to think about demand, supply, adjustment mechanisms, and how we evaluate outcomes. And a lot of the discussion that takes place, particularly in the textbooks, is about idealized systems. Here's an idealized market system and here's an idealized collective system. But we don't actually live in idealized systems. We live in actual systems, and the actual systems seldom, if ever, live up to the aspirations of their proponents. And one of the things you have to be careful of in this policy analysis is people comparing, say, an actual market system with an idealized collective system, or an actual collective system with some idealized market system. Well, that's not a game you should ever allow yourself to be trapped into playing. I mean, it's a silly game to play, but it's very powerful in the political rhetoric, because you know, if you want to, as people do in Britain, if you want to rubbish the National Health Service, you point out all the things that it doesn't do very well, and then you compare it with what some idealized private system would do. And I guess you must face the opposite danger, that people point out all the terrible things that happen in this quasi-market system that you have, and hold up as an image some wonderful collectivized system where everything's fine. Well, it's a dangerous game, and I don't want to get into it. So what I'm doing in the next series of things, which you've got in your notes, is looking at demand considerations in idealized and then actual systems, and then supply problems in idealized and actual systems, and so on. And I don't want to spend too much time on this, but once you get into the swing of it, you can pick it all out for yourselves. I've divided into private systems and public systems, and these are idealized things about demand. In a private system, individuals are the best judges of their own welfare. Priorities are determined by their own willingness and ability to pay. You can deal with catastrophic stuff by fair insurance, and matters of equity are to be dealt with in some other place. I mean, equity is not a business of a market. It's got to be dealt with some other place. So they don't accept any responsibility for that. It's shunted elsewhere. And the public systems say, well, people are always the best judges of their own interests. Okay, I mean, they're just not. And perhaps priorities should be determined by social judgments about relative needs, not by who's got the most bucks to throw around. Okay, not willingness and ability to pay, but some notion of need. And if you provide access to care according to need, you don't have to worry about potentially catastrophic things, because they get picked up automatically. Since the distribution of income and wealth is unlikely to be equitable, you've really got to take this whole system out of that. The provision has got to be taken out of that network completely, where matters of equity could be dealt with. Okay, so that's how the argument gets conducted at an ideal level. But if you look at what actually happens, it isn't the patients who decide what their healthcare needs are. It's doctors who decide what their healthcare needs are. It all works through an agency relationship. I mean, that's what doctors are for. Doctors are to mediate our demand for better health into a demand for healthcare, if that's the most appropriate thing. Now, it may be the most appropriate way to improve our health is not to have anything to do with healthcare, but to change your lifestyle in some way. I mean, so the mediating a demand for health, which comes from us as individual patients, into a demand for healthcare, done by doctors who are themselves suppliers of healthcare and have an interest as suppliers as well as an interest of the people who are mediating demand, is not quite what the market is supposed to operate. The market, the consumer, is king. And it isn't the providers of automobiles who tell you which car you should buy. Okay, you make that decision yourself somehow or other. Okay, so it's a bit different. And it turns out that in the private sector, the priorities are determined largely by the reimbursement rules of the insurance companies. So, so that's a little bit different from what the book said should be happening. And private insurance is itself a profit-seeking activity, or at least it's a break-even activity, which is a slight variant. And the coverage is often incomplete and uneven, and it doesn't reflect personal willingness and ability to pay, and so on. So, and the same down here. I mean, again, we have doctors acting as agents, acting on behalf of patients. Now, not consumers, but patients. And doctors have motives of their own. They're not perfect agents. I'll come back to this in my last session. I think there's a problem about clash between medical ethics as conventionally taught and issues of distributive justice. So I shall come back to that much later on. And here's a problem with that if people don't have to pay anything at the point of consumption, which is the way that collectivized systems are supposed to work, well then there's nothing to stop them going along and seeing a doctor as soon as they get the slightest twinge, because there's no financial penalty involved in doing so. So then you have a problem about what does demand mean in a system where prices are zero. Okay? That's not the kind of thing that economists normally deal with. And the attempt to correct inequities in social and economic system, but simply through differential access to healthcare, is giving a tremendous burden to a healthcare system. I mean, does a healthcare system in Britain have to cope with all the socio-economic inequalities that derive from the entire society? Okay? I mean, clearly it cannot do that. So we also have to think about other sources of inequality in health apart from access to healthcare, which was a major topic of a recent report published in Britain about 3 months ago on the sources of inequalities in health. And it wasn't until they got to chapter 9 that they got around to the healthcare system, okay, as a contributor to this, and quite rightly so. I mean, other aspects of society are much more important. And then on the supply side, I'll skip this over rather quickly, but if you want to come back to it, do. But you've got all this detail in your notes. The suppliers are motivated here by profit and revenue and expenditure possibilities. But in the public system, the suppliers are supposed to be motivated by professional pride and the desire to do good, and so the whole thing is motivated by an ideology of meeting social needs for health and not anything to do with private profit or anything. Well, the trouble with that is that I think people do have some professional dedication and a lot of public-spirited motivation, particularly in the NHS. But the trouble is then that there are always a subgroup of people who can, for example, the NHS generates waiting lists for elective surgery of a non-urgent kind. Alongside the NHS, there operates a small private sector. The doctors who operate in the NHS, generating these long waiting lists, are the same doctors who operate locally in the private sector. Now, could there possibly be a conflict of interest sometime between these two activities? If so, the system isn't going to work quite in the public-spirited way that it should work. Okay? So there are problems on the supply side in both systems. And the adjustment mechanisms that occur are, in a market system, if an activity is profitable, then people flock in and the supply expands and so on. It's not so easy to flock into the medical profession and undercut the other guys and produce and compete away excess profits. Not at all easy to do that, particularly where demand is itself manipulated by the suppliers. And in the British system, the pressures to be efficient are really rather weak. I mean, okay, we have a fixed budget, okay, so we don't have cost control problems, but what pressures are there on doctors to put the resources to the things that do the most good in a health promoting context? Maybe it's better to keep on doing the things you've always done and lead a quiet life and not raise too much controversy about things and operate in a way that leaves you and the people around you comfortable with what is going on. There are some people, very research-orientated doctors, who are anxious to use their NHS practice to expand research possibilities, and then they get into difficulties. That's fine in the long run, but in the meantime they distort their whole pattern of practice because they have a particular research interest which they're pursuing. So routine things that might do a lot of good don't get done. Okay? So then we come back to how can we set up performance indicators to keep control of what individual doctors are up to? Should we have should every orthopedic surgeon be expected to do 2 hip replacements every week, so many knees, so much, etc., etc.? Can you operate the system like that? The answer is, of course, no. You can't go very far down that road. So there are considerable problems there, and I won't go over that, but I will come back to the success criteria. I think in a private system, the consumers will judge how good the system is by their ability to get someone to do what they demand, when, where, and how they want it done. Okay, so it should be in a very consumer-orientated situation, and producers judge the system by how good a living they can make out of it, and that's how private systems are supposed to operate. And public systems, it's the electorate that's judging the system, not the individuals, because the system is serving the population as a whole in principle. It's not serving each individual. And so we look at how far it's improving the health status of the population at large in relation to the resources available to it. That is to say, is it maximizing health given the resources it's got? That's the test which the NHS should, in principle, be being tested by. And producers judge the system by their ability to generate the activities that give them the greatest professional satisfaction, which should be those that are the most cost effective. Yeah, should be. But actually, consumers are worried. Consumers do judge it in the way it was said, but without cleaning themselves out. I mean, that's a little problem, isn't it? I mean, it's not just getting people to do what you want when you want it done and how you want it done, but not impoverishing yourself and your family in the process. So there's a little bit of uneasiness about whether the market is as concerned with that, the second part of that, as it is with the first part. And well, okay, priorities are determined by people's willingness and ability to pay and the cost of meeting their wishes, but people's ability to pay here is largely by the insurance coverage rules, okay, because people don't, on the whole, pay most of the expensive things out of their own pockets. So it's the coverage rules that guide suppliers' behaviour more than anything else. And in an NHS type system, the easiest aspect of health status to measure is life expectancy. So the whole discussion of priorities and success tends to be dominated by issues about mortality rates and life expectancy, with very little weight given explicitly to quality of life issues, which brings me back to my main concerns. And the trouble is that the producers don't have accurate information about the cost effectiveness of the various things that they do. And moreover, they don't always want it because it could be threatening. So the system is much more influenced by professional consensus about what different groups, the orthopedic surgeons or whoever, are familiar with and comfortable with than it is with any real test about whether what they're doing is the most valuable thing they could be doing from the point of view of the health of the community. So the whole system is that both systems are in something of a mess, I would say, if you look beyond their aspirations and instead at their actual behaviour. Their actual behaviour and their aspirations are somewhat poles apart. And it raises an issue, an ideological issue, which I would be quite interested in having a little discussion about right now, and that is, it seems to me most healthcare systems have two broad objectives. Whether public or private. One of which is to improve the health of the population generally, and the other is to reduce inequalities in health. My impression of the British system is that we don't talk very much about this, but we get on with it. And we talk a hell of a lot about this and do practically nothing about it. Okay? And I just wonder whether, do you think, so I think the British system is actually heavily weighted in practice towards this first objective. Not so much towards this one. But I wonder whether you would say, what would you say about the situation in the USA? Would you recognize these two as being important policy objectives, or is there something else going on? To help me to understand the system. Help me to understand what's going on. Yeah.
I think that we don't talk about either of those. We talk about whether an unproven treatment that's expensive is covered by our particular health insurance plan.
Okay.
I think we talk about improving population health care and reducing inequalities in health care without
not health. Okay.
At all. That's my view.
Yeah. Is that, yeah?
Seems like there's almost a sociology of health that is so different, that we are so individualized here, that our community may be very, very small.
Yeah.
That I don't think we look at the community of the United States as a whole.
No.
We're actually fighting between states on organs.
Yeah.
Between the states, and we may feel that we belong to the community of our state. We may even not recognize that. So I'm not sure exactly who we're talking about.
You mean population? You mean what population we're talking about? Okay. You see the population as being quite narrowly defined in most of these discussions.
I'm not sure who does the defining. I mean, I don't.
It also
Yeah,
depends a bit on whose objective that we're talking, who's setting the objective. In terms of the private purchasing community that I'm doing most of my work with now, I don't think these are really, in most cases, even on the table. They kind of want to provide, they want to buy services at the lowest cost and keep the labor unions happy. Getting them to think beyond that is actually quite a challenge. You'd think that the public purchasers might have a bit more, and I think perhaps they do, say in Medicare and Medicaid, a bit more of a goals of the kinds of things that you're looking at, but actually the actions are still quite primitive. So, and that's at least from the purchaser perspective. Now, I don't know, I don't think the patients are necessarily on this chart either. So I think we're a bit adrift vis-a-vis objectives. I don't know if other people would agree with me.
From
Yeah.
the employer point of view, it does mention the purchasing outside of government. I don't think either of those play on the table much. You know, press them, they would go perhaps for the improved population health. Because a better workforce means, you know, I'll make more profit, my company will be more effective, et cetera. But I mean, the real fact is, what's the economics of it? You know, what do we have to pay?
Yeah.
Either keep employees, what do we have to pay to keep them at work?
Yeah.
I think what David's saying is
Okay.
there's
Yeah.
economics somewhere in there that I don't see.
Yeah.
Well, three things, but I think that what differentiates the U.S. from other places is we do it all individually. So there is some individually. So each group in its contracting may or may not have a population health objective in it for that group.
Yeah.
Some do, some don't.
Yeah.
Some don't know what it means, some are afraid of the data, whatever. The reducing inequalities piece, I think the history of health policy in the U.S. says we do it slowly and incrementally.
Yeah.
So we do add to ways to reduce the inequalities, so policies, but it's not in any formal, consistent, big swoosh ways, except for Medicare in 1965 kind of thing. But I agree with Robert that, and my question for you is why you've left off the list anything regarding either cost effectiveness or just cost, distinguishing between the two. And in fact, from what you said earlier, it seems to me one of the objectives of the British system is to make sure that the costs don't go up too much. Whether that's cost effective or not is a separate issue.
Yeah. Well, of course, what I'm doing here is assuming that these are the objectives to be pursued with a fixed bundle of resource, you see, because that's the way it always looks in the British context. There's a fixed bundle of resource. It all comes from one source. So we don't have to worry about what private employers are paying and what the state taxpayers are paying and what the federal taxpayers are paying and all that kind of thing, because it all comes out of central taxation. We don't know where it comes from, actually, because there are no earmarked taxes, and so it just comes out of a pot. And the cabinet decides once a year how much of the pot is going towards the National Health Service and how much is going to defence or education or whatever. So I operate within a system in which I am always implicitly assuming that there is some fixed sum of money which has been determined by some other body according to criteria that may be rather mysterious, and then the money's handed out, and then you're told, this is what you have to do, okay? Or is it this what you have to do? So what you're suggesting to me is that the, what you might say, the ecology of the American system is a lot more complicated than the ecology of the British system, and that's part of the problem. Yes, I'll give you a chance again.
I would say, from my perspective, it's characterized by financial chaos. There is a great shakeout going on, pure competition-wise, amongst managed care companies. There's consolidation, vertical integration, searching for more effectiveness when there's probably little to be gleaned out of the systems that are in place. And it's like we're on the precipice of a shift over to a different approach. And it's going to happen because the costs are out of control. And it seems to me that the employers that are paying the bill are the ones that are going to be the point where the change occurs, because the economic forces are more directly on them than anyone else.
Yeah. Okay.
Could we, before we have our break in 10 or 15 minutes, could we talk a bit about if rationing is the setup to cost effectiveness analysis, which is part of the inevitability of rationing? How do I ask this question right? You imply that perhaps in the British system, because there's so much less resource to go around, the question maybe perhaps gets on the table a little more readily. But I thought you also implied that, and I guess this is my question, even in here there's an abhorrence by politicians and consumers and purchasers, with rare exception, to identify with anything to say, if we know that something is somewhat beneficial, we would not, provide for it. That's just real dominant thinking, even though we know that it goes on in implicit ways. Now, in England, is that more acceptable to politicians and patients, and why is that? Is it just because the resources are so small and so choices are more forced, or are there other cultural and historical things that lead to that?
The politicians have developed the art of buck passing to an extent that would create great admiration, I think, as a art form. And as I said, they typically take the line that any reasonable clinical need, the resources will be there. That's what they say. That sort of phrase. Yeah. So they push the problem down to a clinical level. Now, the doctors in different specialties are, of course, fighting for resources for their bit. So they are always highlighting the things that are terribly beneficial that they would do if it weren't for these managers cutting off their money. Okay, so they're always trying to find spectacular things that they think they're not allowed to do, that they should be allowed to do, and there are always plenty around. And in the meantime, the managers are saying, but, are you telling me that this spectacular thing that you're doing, that everything you do is as good as that? Because if it isn't, why don't you push something else out and make room for it? So, and we're going over to systems of clinical budgeting whereby the orthopods as a group get a lot of money, and they are then left to sort out their priorities for different sorts of treatment amongst themselves and so on. So there's a fighting going on between the managers and the hospital doctors. Now we have another party in all this, which is the family doctors, the general practitioners. And we've just had an experiment for a few years of giving general practitioners big budgets so that the hospitals have to sell their services to the GPs. And so the GPs have enjoyed this enormously. And the joke has been that, whereas in the old days the GPs used to send Christmas cards and Christmas presents to the hospital doctors, and the flow of traffic is now reversed. And the hospital doctors assiduously cultivate the GPs. But it's been well established in the British system for a long, long time that the GPs were gatekeepers. Okay, they decided whether you should be referred to a hospital specialist or not, what exactly should happen to you. Your first point of entry is except for an emergency, is always the GP. And people know very well that the GP isn't going to refer everybody to a specialist, so the GP is exercising some judgment as to whether your needs are sufficiently great that referral to a hospital is worthwhile. And if they do refer you to a hospital, they grade you between urgent, soon, and sometime. And the urgent ones are in the hospital the same afternoon. and the soon ones are there within a week, and the sometime might be anywhere from 3 months to 6 months before you get around to seeing a hospital specialist. And the general public accept that. Okay, this isn't a big deal. I mean, they don't like having to wait, but they wait, and it seems reasonable so long as you believe that if you've got anything really seriously urgent wrong with it, you don't wait, and you don't. Okay, serious things you do not wait, but there's a big waiting list for the rest. So at that level, I think everybody's comfortable. Everybody's comfortable with that bit. The issues arise when there's some new discovery blazoned around the place, and the system has to come to some quick decision about what it's going to do. They've agonized over Viagra. They agonized over beta interferon. When these things come along, they agonize. And then another awkward element in the NHS rears its ugly head, and that is that people say, I live in York, and in York, I can't get this on the National Health Service. But in Leeds, 25 miles away, they can. This is wrong, okay? It's a National Health Service. I mean, either we all get it or nobody gets it. It's not right. But at the same time, we say, we don't want these guys in Whitehall making every decision up and down the country. We want local discretion, okay? So we want local discretion, but we don't want it exercised by anybody. I mean, that's what it boils down to. And I think that bit we haven't really come to terms with the notion that there isn't horizontal equity from a geographical point of view, even though we struggle with it. Okay, and so I don't know how that answers your point, Dave, or whether there were other things you wanted to pursue. But I think like I said, we're in a rather muddled situation with all this. But I think the British population generally does not expect that everything that could do you some good will be done.
Let me just ask before we enter the audience, I mean, are there people here in the American context? I mean, it's easy to say we'll get rid of stuff that's ineffective and inappropriate, right? That's a no-brainer. We just have to figure out how to do it. But what do you think about our ability to say that we might, the reason for cost-effective analysis would be that we might begin to move down the curve, and some of the things that are slightly beneficial but very expensive we might eliminate in order to provide for things that are of greater cost effectiveness. What's the potential here in America for that kind of thing?
Well, insurance plans sort of do that now anyway.
I think managed care does that.
Managed care.
At least if not on a billboard, it does it in fact on a daily basis.
Yeah.
Just things that you think are available, but you can't ever seem to get them.
But there's a subtlety there between cost effectiveness analysis and analysis on return on investment. And I think that's what's driving.
What sort of return on investment would it be? I mean, I can see that from an employer perspective, it's a matter of keeping the workforce happy and keeping them at work, and that's what you're interested in. You're not worried about the health of retired employees or anything like that. I mean, that's not your business. But I mean, when you said it's a matter of rate of return, what do you mean exactly?
Let's say a new drug.
Yeah.
Well, the pharmaceutical company makes a decision that this does have some value out there someplace.
Yeah.
So they will not only put in, one part on R&D and 10 to 15 parts on marketing, but they'll also put in a part of their investment on lobbying and Congress or wherever, FDA, et cetera, to make this all happen.
Okay.
So
Yeah. Well, we have that problem too. I mean, the commercial pressure to adopt drugs and MRI and all this sort of thing, I mean, is really very considerable, and it takes with the high-tech machinery, imaging devices and so on. What they often do is the NHS refuses to buy the thing, so they raise a local appeal. They get the money. They get the money to buy the machine. The NHS refuses to accept it because they want the running costs as well. And then the pressure on the local health authority is enormous, because the local population said, but we raised £1 million to buy this machine, now you say we're going to give it to you and you won't have it. I mean, they say no, because it's going to cost us £250,000 to create the premises in which to operate it. It needs staffing, it needs running, and we got other things to do with this money. So they're getting around to the matter. We look gift horses in the mouth these days, but it's very, very difficult to do. Extremely difficult.
From a cost-effective point of view,
No,
someone that's ready to
no.
learn, it's wonderful.
No, and there's also a problem with clinical trials with drugs, that the drug company pays for the drug while the trial is on, but then it becomes part of accepted practice, and then the health authority says, well, we continue that while the trial is on, but we can't continue to pay these sums of money. So then we're stuck with another commitment, and of course the clinicians involved have invested a large part of their professional career in developing that technology and using it, and they don't want to give it up. So there are a lot of pressures that work against the strict application of cost-effectiveness rules, even when the system in principle is trying to do it. And so we have very similar problems.
Actually, it was in this very room that a state legislator told me a couple years ago that if I thought that he would ever vote for anything down the street in the Capitol that vote against spending for anything that had the teeniest bit of effectiveness, along with a lot of things that he knew weren't effective, that I didn't understand the political process.
Well, that's a good way of raising the percentage of GDP spent on health even higher than it already is.
Right.
I think, is it time for us to stop? I think it is.
We've got some coffee, so
Okay. Okay. Right.